Well, I might get started. Welcome, everybody, and good afternoon. It is just the afternoon. I'm Tom Simonson. I'm the CEO of the Victorian Healthcare Association. For those of you who don't know, the Victorian Healthcare Association is the peak body supporting Victoria's public health and community health services to deliver high-quality care across the state of Victoria. Thank you for joining us for this TriPeaks webinar on MARAM implementation and information sharing. Before we begin, I would like to acknowledge the traditional custodians of the land that we're all meeting on today. For me, that is the Dja Dja Wurrung people of the Kulin Nation, and I would like to recognise their continuing connection to the land and waterways. I pay my respects to their elders past, present and emerging, and extend this to all Aboriginal and Torres Strait Islander people who are with us here today on this webinar. So the TriPeaks Partnership Project is a collaboration between the Centre for Excellence in Child and Family Welfare, the Victorian Alcohol and Drug Association, and us at the Victorian Healthcare Association to promote and support good governance and integrated practice in the child and family, alcohol and other drug and health sectors. Our TriPeaks webinar program is a platform that aims to support cross-sectoral workforces to build capabilities, share knowledge, and promote practice improvement. And over the last couple of years, through COVID in particular, they've been incredibly successful, and it's really good to see so many people attending here today as well. This subject is obviously of great interest to a great many people. The webinar has been developed to provide information about the family violence MARAM framework implementation and information sharing changes and challenges for our three sectors. The MARAM framework was developed following the first Royal Commission into family violence, and it's the policy framework describing best practice for family violence risk assessment and management based on current evidence and research. The framework aims to establish a system-wide shared understanding of family violence and collective responsibility for risk assessment and management. The framework and supporting resources are prescribed for use within our three sectors, health, AOD, and child and family services, and it guides their contact with individuals and families experiencing family violence. The presentations today will cover an overview of the family violence reforms and provide applied information about the role of specialised family violence advisors, how the MARAM framework is used to guide those who work with people who use violence, and the information sharing scheme requirements and challenges in practice. Two of today's presenters are from No to Violence, which specialises in effective evidence-informed engagement with men. The organisation's primary concern is the safety and well-being of women and children. And for almost 30 years, No to Violence has successfully worked to develop safe and effective interventions for men using family violence. There will be a panel discussion at the end of the session where participants can ask questions to the presenters relating to the areas discussed. So our presenters today are Kimberlea Green, who is statewide coordinator, and you can all wave when I say your name. Kimberlea is the statewide coordinator of the Specialist Family Violence Advisor Program in Mental Health and AOD at No to Violence. Courtney Lucanto, I hope I will say all of these names right. Apologies if I get them wrong. Joins Kimberlea for the first presentation, and Courtney is a Specialist Family Violence Advisor in Mental Health in the Mental Health Professional Development Unit at VHA member organisation Bendigo Health. It's actually my local hospital, by the way, Bendigo Health, so thank you. Erin Lockington, who is the Practice Development Lead for MARAMIS, also from No to Violence, and Courtney Magann, who is the Acting Branch Manager for the Inter-Agency Information Sharing Service in the Police Enquiry and Data Sharing Department at Victoria Police. We all like a short and snappy title, so welcome, Courtney. This session today will be facilitated very ably by my colleague Kate Young, who works with us at the Victorian Healthcare Association as a project officer. I'd like to thank you all for coming along today to share your experiences with today's attendees. And I hope that you find the presentations and the discussion engaging and informative. Thank you very much to our speakers.
Thanks, Tom, and welcome everyone. It's great to have you all with us. Before we start the presentation, I just wanted to mention a few things, a few housekeeping items. As Tom mentioned, there'll be 4 presentations and they'll run for about an hour. We will be holding questions until the end, and we will have a panel discussion at the end, and all four presenters will be available to answer some questions around that. So please hold your questions and write them into the Q&A. If you're not aware where the Q&A button is, it's at the bottom of your screen on your PC and the top of the screen on your mobile phone. And if you do like one of the questions that somebody's already answered, to save me trying to find compile all the questions together, there is the option of liking a question, and that will help me to discern which questions are sort of the most popular questions, so that we can try and get as many questions answered at the end. And also, if you do have a question for a particular panelist, please identify that in your question as well. And just to also let you know, we do have a chat function as well, so please just use that if you're having any technical issues or any sort of general comments, and use the quick Q&A button for any questions that you particularly want answered. So at the end, we will also have a post-webinar survey, and I would be really appreciative if you could answer that. It will really help us plan for future TriPeaks webinars. And with that all said, I will hand over to Kimberlea Green, who's the statewide coordinator of the Specialist Family Violence Advisor Program in Mental Health and AOD, and she works for No to Violence. So thank you very much, Kimberlea.
Thanks, Kate. Sorry, mute, I will never get sick of that. I would like to start off just by acknowledging the traditional custodians of the lands that I live and work on. So I'm based in Geelong, the Wathaurong people, and pay my respects to elders past, present and emerging, and extend that respect to any Aboriginal or Torres Strait Islander people in this meeting. We acknowledge the deep connection to country, which has existed for over 60,000 years, and we acknowledge that sovereignty was never ceded, and this always was and always will be First Nations land. I would also like to acknowledge that No to Violence values equity, diversity, inclusion, and people of all backgrounds, including Aboriginal or Torres Strait Islander people and people of colour. We value people of all abilities, diversity of ethnicity, culture, faith, gender identity, sexual orientation, and intersex status. We strive to provide a culturally safe environment for staff and students, and we welcome the unique contributions and perspectives of all people to ensure our work is representative of the communities that we live and work in. I'll now jump straight into a background on the Specialist Family Violence Advisor Capacity Building Program in Mental Health and AOD. So as listed on the screen, I'm the statewide coordinator for the program, and my contact details are there if any of those watching today would like to get in touch. So a little bit about the program. The advisor roles came out of the Royal Commission into Family Violence in 2016, which specified the direct role that mental health and AOD services play in identifying and responding to family violence. So the advisor roles were specifically designed in response to recommendations 98 and 99 to provide family violence expertise in mental health and AOD services to facilitate cross-sector collaboration. So the program was rolled out in two stages. So in stage one, that happened around in 2017, and advisors were placed across 17 areas in key specialist family violence agencies across Victoria. So in stage one, advisors worked with key mental health services and AOD agencies in their areas, with statewide coordination provided by Domestic Violence Victoria. The program back then had a framework and guidelines for that stage one, and that was developed by FSV, so Family Safety Victoria. Stage two began in June 2019, and advisors were embedded within department-funded mental health and AOD services rather than within family violence agencies. So the positions are ongoing and are auspiced by mental health and AOD providers. So Courtney Lucanto, who's the specialist mental health specialist family violence advisor, will chat to you later in her presentation about her role specifically and how that works. So a little bit about the advisor program. Currently we have around 34 advisors sitting across the state in mental health and AOD services. And in 2021, our advisor guidelines were redeveloped and released to provide program guidance for service delivery. So the guidelines essentially support consistent statewide delivery of the program, describe responsibilities, clarify activities that the advisors do, and confirm reporting requirements. So the advisors complete quarterly surveys and an annual survey as well. And I guess Courtney as well, she will, Courtney the advisor, sorry, there's two Courtneys on the panel. She'll be able to specifically speak to her responsibilities and her and what she does in terms of MARAM and how it connects to sort of the program as well. A little bit about the governance structure. So the advisor program has a statewide steering committee, which was established in 2020, and it provides statewide support, direction and leadership to advisors and aims to improve family violence capacity building within mental health and AOD services and cross-sector collaboration to ensure better outcomes for clients. As I noted earlier, the advisors have 5 responsibilities, and the responsibilities are just listed there on the slide. Although the responsibilities are the same across the state and the program, the advisors sitting across the state, their roles and responsibilities may vary, I guess, depending on organisational needs and the FTE of advisors. So some advisors are full-time, some have smaller FTE, so it depends on organisational needs as well. So the first one, build family violence capability and capacity, and advisors respond to AOD and the AOD and mental health sector, and they do this by participating in any relevant forums, meetings, events, and provide family violence advice, knowledge and expertise around MARAM, Family Violence Information Sharing Scheme, the SIS, and facilitate any training or information sessions to their organisations and sectors. They update policies and procedures, and also develop resources in partnership with their agencies, and support their agencies with change management activities as well, relating to MARAM and any other reform work within their sectors. This is also something that Courtney will touch on in terms of capability and capacity building. The second responsibility is supporting collaboration. So this is a core element of the Family Violence Royal Commission recommendations to respond to family violence. So collaborative practice through referrals, secondary consultations, case coordination, information sharing helps keep the victim survivor safe, and helps keep perpetrators in view and accountable as well. Another important role of, and responsibility of the advisor is around secondary consultation. So clinicians within the advisors' organisations can seek a secondary consultation from an advisor to gain family violence expertise and knowledge, and also support with their response to make sure victim survivors or people using violence are provided with the best sort of referrals, or in terms of managing risk as well. Advisors don't undertake direct case management or provide face-to-face support with clients. However, they can support the clinicians to do so. And Courtney can speak to that as well. The fourth responsibility is around MARAM and supporting MARAM alignment and embedding. So as prescribed state-funded services, AOD and mental health are required to align to the policies, procedures and practice guidance and the tools of MARAM. So advisors have extensive knowledge and practice guidance on these tools. However, their, I guess, main role is not to provide project work to their organisations, but more so to support their organisations in aligning and mapping their organisations to MARAM. Courtney will also touch on this. A lot of these responsibilities Courtney will expand on. Then the last responsibility for advisors is engaging in statewide activities. So advisors, as I said, there's 35 advisors that sit across the state within mental health and AOD, and to ensure collaborative practice occurs across the state, we have a monthly communities of practice. We have program reporting, which advisors do, and also we have our online platforms which support collaboration across mental health and AOD advisors. Thanks, Jen. Just on to the next slide. So statewide coordination, as I said, is provided by myself, and I've provided that statewide coordination for the last 8 months. And I am the key point of contact and representative of the program. So as I said, I facilitate the communities of practice, provide one-on-one support and advice to advisors, and support collaborative responses with peak bodies and government. So I work closely with VADA, the Centre for Mental Health Learning, FSV, and the Department of Health, and as well as Safe and Equal. As I said as well, we provide a communities of practice, which provides a safe and respectful learning space for advisors within the mental health and AOD space. I guess with these communities of practice, we ideally like to discuss any issues or barriers or gaps within the sectors, but also within the roles to increase collaboration and support for the program and advisors, and any advocacy pieces as well. Yep, thanks, Jen. And then here's a little bit of information. So as I said, I'm employed by No to Violence, and as part of No to Violence, we have the men's referral service. So there's a bit of info on our men's referral service, and also the brief intervention service, and the MAX program as well. I will just note as well that I'll pass over to Courtney now, but as I said, she's a mental health advisor within the program. I guess it's important to note that whilst Courtney will provide an overview of her role at Bendigo Health, advisor roles across the state can have varied responsibilities, and their roles may look a bit different. So just bear that in mind. I might pop a little bit of information in the chat, and Kate, if you're able to share this when you post this recording, which provides a fact sheet overview of our program, and as well as a contact list for advisors that may be in your region. Thanks, Kate, and I'll pass over to you, Courtney.
Thanks, Kim. I'll just wait for the PowerPoint. Thank you. Thanks for putting that up, Kate. So as mentioned, I'm Courtney Lucanto. I'm one of the 2 Courtneys on the panelists today. I work at Bendigo Health. I'm a specialist family violence advisor in mental health. I've also got my email address there. So if you're interested in any sort of collaborative opportunities with this work and you're within our region, you're welcome to, make contact. I'd also like to acknowledge today that we're meeting, and I'm coming to you from the land of the Dja Dja Wurrung people, who are the traditional custodians of the land that I sit up on in this Bendigo area. And I'd also like to acknowledge that it's NAIDOC week this week. I'd like to pay my respects to leaders and elders, past, present, and emerging, and they hold the memories, the traditions, the culture, and the hopes of all of our peoples. I'd also like to recognise the resilience, strength, and pride of the Aboriginal community, and we express our gratitude in the sharing of this land, our sorrow for the personal spiritual cost of that sharing, and a hope that we may walk forward together in harmony in the spirit of healing as well. If we could click through to the next slide. So when we're talking about the conversation around MARAM or MARAMIS, depending on which acronym you're interested in using, for me, it's really important that we centre some of this work. I think this is vast work. It's occurring across a range of different service sectors, But I'm really hoping today, in the time that I have, to sort of shed light on some of the practical work that we've been doing and what this might look from that practice level as well. My PowerPoints, as you see, very deliberately only come with a couple of dot points. And so I'm hoping that you'll be able to engage more with the dulcet sounds of the tone of my voice. And if you have any things you'd like me to expand on, just pop it in the chat and we can get to those questions after. So with these 2 dot points in front of you today, the thing that I really also want to draw about is mental health and the health alignment activities that have been occurring in a broad context of ReFirm. And this first level of alignment activities, we really have to understand that MARAM and businesses alignment work really has to have been centered in working with victim survivors. I think it's something that when we do this work for an amount of time, we can sometimes feel a level of, well, quite frankly, change management or reform fatigue. So a lot of us kind of want to skip ahead to the people using violence work, or we have more concern, or we might have more angst about it. But the central element to sort of center yourselves in doing this work, and for us at Bendigo Health for doing this work, is to get our alignment work how it needs to be for working with victim survivors, because we know it's a central element to then undertaking work with people using violence later. At a practical level, this phase of reform has occurred first for us across the service sectors. We know that because of the release of things like the practice guides and the training from government. Strategically, however, in order to work safely with people using violence, we also know we need to centre the voices and experiences of victim survivors at the heart of all of our work. You actually can't work with a person using violence safely if you don't hold the voices of victim survivors in our own systems and in our own practice. So it makes sense that we've actually undertaken this reform work within our own systems and our practices with victim survivors in a considered way. We've undertaken this work, like I mentioned earlier, with that change management fatigue in mind, with a change management focus to help support cultural and practice change. And we've been working to implement a range of reform in a way which minimises this change fatigue in staff. We're mindful of the intersecting reforms, which are also occurring for mental health and with the Royal Commission into Mental Health Services. And if you were from mental health service sectors, health, you're from AOD, the Mental Health Royal Commission is a big deal for us as well. So this is really an acknowledgement to call out that if you are working with these service sectors already, you've actually got this potential load of intersectional reform happening, and sometimes that can feel like a lot of work. And if you're actually acknowledging it in the first place, if you're calling it out, if you're inviting some accountability and visibility, it helps with this overall reform work with family violence as well, because it is transformational work, which we've been doing. When we talk about the MARAM alignment activities at Bendigo Health, it's important to highlight that we've been doing a range of activities. Other hospitals and health services and mental health services across the state have also been doing a lot of it. So Kim was right in acknowledging that there might be advisors in your area as well. Some of them may have been participating in work that looks like this, others might not, and that's okay. For me, it's just about calling out where we're at as an organisation too. Some of the activities that we've undertaken have included things like, at a variety of different levels, establishing and participating in family violence reform steering committees, which have executive leadership. One of the things that we found integral is actually that engagement of leadership at a variety of different levels, not having just a bottom-up or a top-down approach, but actually going, we have the right people at this level on these committees. Now, what do we need to do to actually engage multiple other levels of leadership on this committee as well? That's looked like actually leveraging on a lot of relationships and collaboration. If any of you are from regional areas, you will know about the importance of relationship building. I think sometimes we've just been doing it for so long because we've had no one else and nothing else to offer. So we go, oh, we have to relationship build because that's all we can do. But it is incredibly important in this work, because the reality is if we can actually get some of this relationship work at a really solid level, the trust that you build with it is incredibly important. It becomes your allies in this space. So for me, that collaboration's been both internal and external. At Bendigo Health, that's meant, as my role as a specialist family violence advisor, collaborating with what's called the Strengthening Hospital Responses to Family Violence, SHREV project work. Some of you are probably even from SHREV today, because I have recognised a couple of your names in the participants list. So I know that can look varied across the state, but for me, I know we did this strategically. As at Bendigo Health, there's actually only the total of 3 of us. There's 2 part-time roles in SHREV currently, and then my role across our organisation of 5,000 staff. So mental health at Bendigo Health has about 500 staff, and we're spread across a large geographical location that covers the Loddon Campaspe and then the Southern Mallee region as well. We got just Swan Hill. This means that all of our activities have to be a whole of hospital approach. So things like, you know, anything that kind of raises the profile, things like the 16 days of activism for family violence activities, we highlight mental health as part of this. So it's really important that as a mental health service sector, we haven't just got consumed by that broader health identity, but we are part of it. And we don't sort of want to other ourselves in kind of becoming invisible in that either. So that's some of the work that, even though it's collaborative, we have to actually acknowledge that. We have to name it, because if you create some of that visibility around it, it really helps with then going, actually, now how do we pivot to this? What do we kind of do to work with it? Which brings us to our very exciting MARAM alignment plans. If anybody's ever seen these documents across their own organisations, they're quite intimidating because they just have a range of reform activity at a range of different stages. And it can feel quite overwhelming, that whole language that government's used about MARAM being a maturity model. We know that's true, but it can feel like a bit of a hard slog. And so that's where actually acknowledging this sort of work in time constraints, in ways that measures it, is really important, so it doesn't sort of feel like this change fatigue is kicking in all the time. We have things like piloting of our assessment forms under the MARAM in mental health. We've had to actually go, right, these are the MARAM assessment forms for the various stage of assessment. Where do we put this into our current assessment forms? Because in mental health, we actually have our own risk assessment and safety planning about mental health. So what does that look like for us to think about? All right, now we take this holistic lens of risk assessment, including family violence, with these tools that have been created. How do we actually align them to the current assessment tools for staff? And how do we do it in a way which supports that, rather than makes them feel like they have to do an extra level of assessment and it sort of sits a bit separately? That's an ongoing piece of work, to be honest, because that's something for us that our systems, which are our things like our electronic patient record or our mental health digital medical record systems, they obviously weren't built with this whole conversation around MARAM in mind. So it's kind of retrospectively going, actually, what does this look like? At what stage can we actually drop this in? What does this look like financially? And what's the timeframes around it? So we have to be quite okay, I think, with sitting with some of that complexity and knowing that each of those changes actually is a shift forward, and taking stock of that. There's been things like our protocol development, so things like refining our family violence alert in our EPR, which is our electronic patient record. We're doing things like our MARAM aligned family violence assessment response protocols. A lot of the work that SHREV in the hospitals have been doing for such a long time was really creating this presence for family violence, actually understanding family violence as a health issue. Now it's about elevating that and going, actually, now this is part of this legislation. This is actually how we start to really push it along and get this energy. I know that we've also done things like under FIS and CIS, the Family Violence Information Sharing Scheme, the Child Information Sharing Scheme. We've implemented our centralised information sharing scheme protocols so that for an external service seeking information from our organisation at Bendigo Health, they just fill in a one-page form and then it just gets sent to a centralised email address. And from there, it then actually gets sent out to the relevant treating team and clinical areas. That is a really simplified way for external services to feel that sometimes when they haven't really been able to reach different risk relevant information, or they're not sure where to even go at the start, if they go to this one entry point, it's our job as an organisation to then work it out. What we want them to be doing is going, actually, this information could be with this organisation. It is. We need to reach out, we need to implement this. And then our staff actually going, all right, and this is what we need to do to respond. So a lot of that has also involved staff training to support them in responding, to drawing out risk relevant information, to fill in those information sharing requests. That has also meant things like training modules, things like implementing e-learning training modules, but also then going, all right, if we're in a clinical world that's 24/7 and we have night shifts, we have units in mental health which are staffed 24/7 in our inpatient wards, Do we just rely on that as a training module? And the answer is actually no, having a hybrid model to go, which parts of our service system do we need to lean into to go, actually, this is where our staff are at. This has been current issues. How can we be adaptive? And that's part of my role as an advisor, to be thinking through some of those things as with the organisation and adapting to it. And a large piece of work in actually understanding which training staff need to go to, which assessment forms they need to be thinking about completing. That means we've had to undertake workforce mapping in relation to which staff members undertake which training modules, and I'm going to talk to that further in a little bit. If we could flick through to the next slide, that would be great. So this kind of screenshot is just a little bit of an idea about some of the mapping processes. We, again, have had to start it for working with people who work with victim survivors. And it's really important that actually we potentially have had to do this mapping differently. So this was, again, at the whole of hospital. So on this screenshot in front of you, you can see some of the amazing work that Shrev was actually doing. And then I was working collaboratively with them to go, actually, this is the level of mental health roles. These are the ones within mental health that might look different across the hospital, even if they are potentially a generic role, like a registered nurse, for example, or a social worker. They can have different implications. These aren't homogenous roles. And I think that's also the call out in this piece of work, that when you're working within these service sectors, you do know your organization's the best, you do know your workspace is the best. So actually understanding, if you have to undertake this sort of complexity, which a lot of you have if you're in health or mental health, how does that then translate? And how do you actually communicate and hold firm on some of this knowledge base? For me, I think to just understanding that this was the first piece, that whole of hospital process, and really, again, centering on people who work with victim survivors. This included, though, consultation for the range of workforces with clinical heads and leaders across all of them, including mental health. But we have to also understand that this then type of mapping process is going to be also used for people using violence. And we know things like mental health staff are actually mapped at a brief and intermediate level of responsibilities under MARAM. But again, the roles in mental health are not homogenous. So we have the complexity and vast, richness of our lived experience workforces. And sometimes they get risk relevant information, but we know they actually won't be completing an intermediate risk assessment under MARAM. It's not clinically appropriate. So our lead clinicians in community teams, however, would be. And a social worker in an inpatient unit would be, but an EN nurse, they might not be. They might be undertaking a screening and identification level of assessment instead. They're the types of things that really knowing the workforce has been really helpful. And I think just calling out earlier, as I'd mentioned, that in mental health, we actually already have a variety of current assessment tools in relation to mental health and risk. So the inclusion of family violence risk really, for me, supports a more holistic understanding of risk and the intersections between family violence and mental health. And that's how we've started to shift these conversations so that haven't felt as siloed as they might have previously. The inclusion of this family violence lens helps us in mental health to understand sometimes the deterioration or changes in a victim survivor's mental health and the impacts of the behaviour of the person using violence under this. So under MARAM, using this framework, we hold a trauma and violence informed lens. And that's kind of one of those important shifts, I think, that's really exciting for mental health to be participating in. It also brings us to the next point. Our mental health service system has different entry points, and also because of this, disclosures of family violence occur at different points for people in their mental health recovery and journey. So we might not receive information, or we could potentially. Sometimes we hope we might receive information proactively from another service who informs us the client we are working with is a person using violence. We might not have had that type of information before. It's helpful to receive this information with the evidence-based risk factors highlighted under MARAM. This is the type of collaborative practice, when I'd called it out sort of previously externally, that actually starts to make a difference for clients' journeys. These evidence-based risk factors under MARAM, they inform our work with people using violence as well. If somebody is our client and they are a patient and they are the ones using violence, what does it look like for us to keep that in mind? How do we support collaborative risk management practice across our service sectors with this? So the next focus, as I mentioned, will be the mapping our whole of hospital workforce for working with people using violence for our staff. And what does that look like at a variety of different levels? Could we go through to the next slide, please? Yep, perfect. So the practice reform, again, Kim mentions that I'd talk to some of this in a few bits of detail, which I will. I think under this, again, under MARAMIS, the practice reform under MARAM Phys and SIS, we know occurs at different levels doing this work. This work fits within the responsibilities of the advisor role. So for me, things like training and education, that's occurred throughout my advisor role staff, including things like working with our medical workforces. In mental health, it's important to understand the treating team environment, and those of you who work in that already, you really will get that, and the roles which consultant psychiatrists can have in leading and supporting this work. I'm really grateful to the relationships which I've developed and the trust that I feel with some of the staff in these roles at my organisation. They're very invitational in their approaches. They contact me proactively. They are invitational in inviting me in to team meetings if needed. So I work with our psychiatry and registrars and our HMOs also across our services. This is an integral role, and I also roll out training throughout our doctors in training orientation sessions. So when they rotate across from medical wards into mental health, this helps to build ongoing capacity and again highlights the unique factors when it comes to mental health and family violence. You also have to think of this training and reform across, I guess, almost the lifespan really of our service sector and who's in it within our own workforce. So I also do some things with our nursing grads. They're our future and our ongoing workforces. The other interesting thing about this workforce is they get different information sometimes that other clinicians might not get. So sometimes people using violence actually try out different behaviours on junior staff. And it's important that as a workforce, we actually create a visibility to that messaging and understand it's part of a collusive pattern from people using violence. In some of my secondary consultation work, I've spent a lot of time with staff actually calling that out and naming that so that people can really understand that that's not actually something that is directly a result of what they're doing. It might be invitations from the perpetrator initially and the person from using violence. So how do we manage that and how do we support that for staff? The other things that I'll briefly touch on here, because I'm mindful of time, is the coaching and mentoring. So working with staff to undertake MARAM in practice. As an advisor, attending things like external professional meetings with staff really helps to cement this because you're actually undertaking modelling to staff how to utilise the shared language of MARAM and also the family violence risk to hold people using violence in a view across service systems. It's one thing to just sort of say the words MARAM, but actually how do we describe the risk behaviours from the person using violence that we're seeing with? How do we name the behaviours? It's one of the things that I really love about working within mental health and health. The strength of our workforce is in the observations that they're able to document and they're able to see. We have a really, really great observational lens in our workforce. So actually, how have we described what we're seeing in front of us and how have we described what the person using violence might be saying to us, or how have we described what the victim survivor might be saying to us? How have we documented that as well? The other part that we use in regards to Phys and SIS, so we proactively share information under the Family Violence Information Sharing Scheme. We do this quite regularly. We know we work with people who use violence as their patients, as clients. The acuity of their mental health, we know, isn't the reason for their choices to use family violence. So we're very clear that we don't engage in any sort of myths that exist about people's choices. We know that people make choices around their use of family violence. So what we hold, though, is information is the intersection of their mental health issues and how this can escalate risk for victim survivors. For example, if someone using violence is getting discharged out of our service, out of our inpatient wards, who needs to know this and how have we considered this as a service? And also, even initially, how have we established that they are a person using violence? How have we used structured professional judgment under MARAM to undertake our own Phys requests to see what the broader service system knows about their patterns and use of violence? I'm really clear with staff that if we undertake a family violence information sharing scheme about a request about somebody using family violence, if an information sharing scheme request is returned externally and it doesn't highlight a pattern or a history from those services, it doesn't mean that they aren't a person using violence. It just means that that knowledge isn't held yet by those service systems. So it also tells me the risk that we have there is potentially victim survivors sometimes disclosing and exposing that person using violence for the first time. So we have to actually think about it in that way. It doesn't mean there isn't a level of risk. What does it mean actually for the level of risk, though, and how do we actually respect that and undertake it as a serious understanding? So we have to consider things like if we do get these information sharing scheme requests returned, how do we understand that broader service system? How do we understand who knows about their patterns and use of violence? And then we have to consider what other services are already working with the person using violence, or if we're the only ones. And that can include things like finding out someone's on a current corrections order, for example. And if that's the case, okay, what are those conditions about? Is that actually a referral to an AOD service sector for AOD kind of work and counselling? Is it something that they've got forensic mental health counselling? How do we have an understanding, and who's got some visibility about their patterns and use of family violence, and how can we tap into that collaboratively? So we do a lot of professional meetings, I would say, where we actually share that information under FIS and CIS thresholds if we don't have consent to do so. The other key aspect, as you can sort of hear earlier from Kim's presentation, is the secondary consultations. It's a key part of the advisor role. As you've heard directly, advisors don't work with the clients or the patients of our service sector, but we work with our staff who do. So if we're working with staff, this helps to pick up patterns of what people using violence are doing. We can notice also differences in teams. This is also relevant across the teams when you work with different parts of the developmental lifespan for clients and patients, because family violence can actually look different in the behaviours and the complexity when you're working with people who are older, adults, adolescents, and working with children. So we have to consider how we undertake family violence informed, family inclusive practice across a range of settings. We also consider how family violence risk can present for different parts in our service sectors. We sometimes know this can look different for our residential teams who work with people with AOD and mental health issues. This can be different for people working with patients in an inpatient unit, and then the risk for a client in the community could be different again if they're currently living with the person using violence still. They're the sorts of things we have to actually think about and start to shift our service sectors continuously to reform, to go, actually, this might be an entry point over here, and how does a person using violence actually stop somebody needing to access our service system if they're a victim survivor, or how do they actually escalate their behaviour if they're trying to do that as well. So we get information about this through things like FIS and CIS, and then through those secondary consultations with staff, I can support them in those professional meetings, and we get information about this work with clients and other services collaboratively under MARAM to start to form quite solid risk management plans as well.
Courtney, I'm just going to interrupt you there. You're almost done. I'm just mindful of the other speakers. Thank you.
I am. So this is the final slide. And so this is where I just briefly wanted to touch on some of the family violence within the mental health context. So for us, it's really important to highlight that there's different dynamics and risk factors. So as part of this alignment work with MARAM, we know it's been working with victim survivors, and the next phase of this implementation in system alignments for working with people who use violence. And part of this is to understand the complexity of how family violence is evident in our service system and some of the nuances around risks that exist for mental health. So I just wanted to put a couple of things for people to call out and consider. So this is current issues for us, but it's also got a couple for future as well. There's a complexity of mental health settings and sectors. So we have things like the Mental Health Act 2014, but as you know, we've got a new Mental Health and Wellbeing Act. So we have to consider what are the implications for family violence and information sharing schemes under that. And that's a current issue for us in still actually figuring out what this intersection looks like. The other one that I want to call out is the duality, the fact that we work with people who are victim survivors in our service sector, but we also work with people using violence, and they can be both our patients and our clients, but they can also be people who masquerade as carers, and they really do abuse the people who are meant to love and care about the most. That's the sort of thing that I think sometimes people miss around this intersection around family violence here. And using things like the information sharing scheme really helps us to actually cement this for our service sector and go, actually, this is the complexity of risk you're dealing with, and this is how we start to get some answers around it. Our staff have found that quite empowering. And the other one that I just wanted to call out as well is the misidentification of family violence and trauma. So that's a constant ongoing conversation we have, and part of what has been helpful with the family violence information sharing scheme is highlighting so that if we have a female patient and she's kind of been had the police called on her when she's more escalated or unwell, and he as a perpetrator, a person using violence, has really gaslit that, having the information sharing scheme, having his pattern of family family violence and how he's manipulated the intersections, identity of her having mental health issues, has been really helpful for our service system to understand the complexity of her experiences and also the ongoing impacts of that trauma as well. So that's my slides. Thank you for giving me that time.
Thanks, Courtney. Thanks very much. That was very informative. I just wanted to now introduce Erin Lockington, who's the Practice Development Lead for MARAMIS, also works for No to Violence. Thanks very much, Erin.
Thanks, Kate. I also would just like to begin by acknowledging the First Nations lands we're meeting on, and for myself, I'm calling in from Wurundjeri country today. And as Kim noted earlier as well in her presentation, NTV also wants to acknowledge that we value equity and diversity and inclusion of people of all backgrounds, including people of all abilities and diversity of ethnicity, culture, faith, gender, identity, sexual orientation, and intersex status. Thanks, Jen. I'll jump to the next one. So today I'm just going to give a very brief and very broad overview of MARAM, with a bit of a focus in on adults using family violence. So many of you, of course, will already be familiar with MARAM, others perhaps not so much, or perhaps be aware of perhaps particular elements of it, such as the work with victim survivors or the information sharing schemes. Just to start, and Tom mentioned this at the beginning, and Courtney has also given an overview. So MARAM, in terms of the framework, is the policy framework that outlines best practice for family violence, risk assessment and risk management. So this diagram is always just a helpful one to start with, to remember where we're coming from. So we've got the pillars. I'm sorry, I'm hearing that there's a bit of background noise. Can you still hear me okay? Yeah. So pillar one is around the shared understanding of family violence.
Erin, can I just interrupt? Sorry, is that background noise coming from you, or no? Not coming from your...
I'm not too sure. It might be if everyone else is on mute. Can you hear what I'm saying okay?
We can hear you, but we can hear someone speaking in the background though.
Okay, I'm sorry about, yeah. I can try and jump into another room if that's helpful. Just 1 second, sorry. Sorry, just an awkward trip through our office. Let me try this room. Okay, so yes, pillar one, shared understanding of family violence, and that's really around the evidence-based risk factors and impact, understanding the different types and drivers of family violence, as well as the diversity of experiences and relationships across the community. Then we've got pillar two, which is the shared approach to identification, screening, assessment and management of family violence risk. So we're looking really at the tools in that section in particular. Pillar three, around the outlining the responsibilities of professionals in risk assessment and management, and I'll touch on that in a little bit more detail in a moment, but making sure that we've all got consistent expectations across the service system. And then pillar four, around the systems outcomes and continuous improvement. So making sure that we've got that system-wide data collection, that we're monitoring and evaluating the tools and processes. Thanks, Jen. So in terms of where we're up to in the rollout of the MARAM practice guides, so again, a lot of you will have a lot of familiarity with the victim survivor guides, which were released in 2019. In terms of the guides working with people using family violence, in July 2021, we had most of that practice guidance released. We just didn't have the comprehensive level guides. in March this year. The comprehensive guides have been released, and so that's for specialist family violence services who are working in perpetrator interventions. So at the moment, there's just a targeted release for those practice guides, so they're not publicly available at the moment, and that's just around mitigating the risk of quite detailed information being used by perpetrators. But there will be future opportunities for other services mapped at identification and intermediate to gain access to them. It's just a bit of a staggered process at the moment. And we also have the training for the adults using violence guides. The training development is underway, and there'll be further information about that release later this year about when that's coming out. The other piece of work that's still to come is around adolescent focused and child and young person practice guidance. So that's both about children as victim survivors in their own right and how we can work more extensively in that space, as well as young people who are using violence and force in the home. So just to look a little bit more closely at the adults using family violence guides. So these were developed by FSV, working with Curtin University and No to Violence. So these were developed with consultations of academic subject matter experts, as well as, of course, extensive consultations with workforce practitioners. And we also had user testing and piloting of the tools. So as you can see, the adults using violence responsibilities correspond with the same responsibilities as with victim survivors. So what we have highlighted in purple here is all of the responsibilities that all agencies prescribed to MARAM will need to fulfill. So we've got that responsibility 1 and 2 around being able to sensitively engage with clients and identify behaviours related to family violence. And so really at that identification level, we're talking about people being able to know the evidence-based risk factors and a real focus on observation of a person, whether that's their behaviours or whether that's the narratives, violence supporting narratives that are coming through in conversations that you're having with someone that might flag to you that they are using family violence. Responsibilities 5 and 6, so around consulting, referring and sharing information. And then responsibilities 9 and 10, so that's the multi-agency coordinated risk management and collaboration. Then as we move on into the intermediate level of responsibilities, so for professionals mapped at this level, they'll have all of the previous responsibilities that I spoke about, but also will have the intermediate risk assessment and risk management. And so that's when we're asking people to start forming a professional judgment around the seriousness of risk that a person may be using family violence. And also that the risk assessment, we start to get into a space where it might be informed by responses to prompting questions that a practitioner might be asking. So there's a conversation model that can be used to start garnering some of that information. And that there's a responsibility there around a risk management plan and possibly, if safe and appropriate, a safety plan that you might do with the person as well. And then finally, we have the comprehensive level responsibilities. So at this level, we're talking about people who might be working in behaviour change programs, justice, child protection, Orange Door. So these practitioners at a comprehensive level have to have the capability across all the MARAM responsibilities. And then at that comprehensive level, they're gathering a lot more detailed information around risk. They're doing that direct assessment with the person using violence. Again, where safe and appropriate, they're really developing a comprehensive safety plan with that person and taking on a leadership role in risk management and planning. And I should say alongside this as well, the Foundation Knowledge Guide was also updated when the Working with Adults Using Violence Guide came out. So there's a lot more information in there too around kind of strengthened definitions of coercive control, key concepts for working with adults using violence, and some updated information as well around presentations in different relationships and communities. So I'm not going to go through a bunch of tools and templates today due to time, but also due to the fact that your organisations will map you. They'll let you know when and when training's available and when you can start using the tools. But I guess just really broadly looking at some key concepts that are across the guides, whichever responsibility you sit at. So when we're working with adults using violence, these are the MARAM key practice concepts. So the first one is around keeping a person in their context approach. So we know everyone has a different identity circumstances that affect their choice to use violence. And what we're asking to do is understand what impact that's having on the person's choice to use violence, but also when we're doing that, and as Courtney had outlined, that we really need to keep a focus on the victim survivor's experience and safety at the centre of that engagement, even when we're taking in the context of the person who's using violence. Holding an intersectional lens as well, so we know that this can affect how people using violence might engage with the service system, barriers that might be in place, how they might be disclosing or talking about their use of violence, also how they might be, how their behaviour might be impacting or targeting the victim survivor's identity as well. Holding a trauma and violence informed lens, so not the same as excusing behaviour, but certainly we know that people who use violence may have an experience of trauma, whether through childhood, colonisation, migration, and that that experience of trauma can impact the change or the escalation of violence that they're using. So really needing to think about how we can support that person to take responsibility and how we mitigate that risk of escalation. Safe and non-collusive practice. So again, collusion referring to the way that a person might invite an agency or a professional to reinforce their minimising or excuse of why they might be using violence. So we know that this happens, we expect it to happen, but making sure that, when we are engaging, we're avoiding reinforcing behaviour that rewards that use of power over someone, but also avoiding validating the person's violence supporting narratives. Reflective practice, so obviously we all have different biases learnt through our different cultures, families, attitudes, so needing ourselves as practitioners to be very self-aware in knowing how this has informed our identity and being very conscious of any biases that we hold, and that this isn't becoming assumptions in the risk assessments that we're making. Structured professional judgment, I'll touch on that really quickly in the next slide. And then risk management is the last one. So again, really maintaining a focus on victim survivor safety and actions that are holding that person using violence in view, holding them accountable for their behaviours. And important to flag that when we're working with people using violence, risk assessment doesn't always mean that direct work with a person. There's lots of ways that we can be reducing or removing the risk that they pose: information sharing, collaboration, ongoing monitoring, linking them in with other services to support their needs. And just very briefly, because I'm conscious of time, this was another key concept throughout the guides in both the victim survivor and the adult person using violence guides. So structured professional judgment is that practice model that underpins risk assessment to support us to determine the level of risk and inform our risk management responses. So again, we can see that victim survivor self-assessment is at the core of that. When we're working with a person using violence, we might have direct access to a victim survivor and their assessment, we might not. We might get it through information sharing, but there are also other ways that we can always consider how we hold their experience at the forefront, you know, questioning how this would make them feel, how their identity is being targeted. Identifying the evidence-based risk factors that are present. So this might be direct disclosures and admissions from the person using violence. It might be, again, info sharing from the victim survivor. It might be what you're observing, or it might be from other services or police notifications that you're receiving. Then we've got the layer of information sharing, again, largely through the FIS. Courtney's going to talk more about that in a moment, so I'll just leave that one for her to explain more. And lastly, again, just intersectionality, as I mentioned before, how it might shape the way a person's violence is being expressed. So, and then yes, of course, using then our professional judgment to make that assessment on the seriousness of family violence risk. So that was a super quick overview of MARAM, and I apologise about the interruption there of the noise. Just going to say that, you know, if anything to take forward today, I just encourage you to be having a look at that foundational knowledge guide, just starting to get acquainted with those key practice concepts. What are you familiar with? What are you not familiar with? And how can you start to build some of that awareness before the training then later becomes available? Thanks, Kate.
Thanks very much, Erin. And yeah, sorry to rush you there. We've now got Courtney Magann, who's going to present from Victoria Police. She's the acting branch manager of the Interagency Information Sharing Service. Thanks very much, Courtney, and don't rush. We've still got heaps of time. So, yep, looking forward to hearing from you.
Thanks, Kate, and thanks to all the other presenters. It's great to be here today. So as Kate said, my name is Courtney. I'm here today from the Interagency Information Sharing Service here, or the IS team at VicPol. I'd also like to begin today by just acknowledging the traditional custodians of the land on which we all meet. For me, it's the Wurundjeri peoples of the Kulin Nation, and I pay my respects to their elders past, present and emerging. I recognise the continued connection to the land and waters of this beautiful place and acknowledge that they never ceded sovereignty. I extend that respect to Aboriginal and Torres Strait Islander peoples here today. So I have been asked to come and talk to everyone today about the information sharing requests made to Victoria Police and to cover off some elements around these requests that may be beneficial to anyone who wishes to access Victoria Police information under the Family Violence Information Sharing Scheme or the Child Information Sharing Scheme. So today I'll be discussing the following subjects. So what does the information sharing team do here at VicPol? Who makes up our team? How do you make a request with us, and what a response from us can provide and look like as well. So towards the end, I will also obviously invite any questions along with the rest of the panelists. So if there's anything you do think of, please take a note, and yeah, happy for you to ask me. I'll also keep my details up towards the end and pass it on for the webinar for anyone that may wish to reach out separately as well. Before I also proceed any further today, I want to advise that I have provided some real report example information with identifying information redacted. Some of this information might be considered distressing, and if you do need to step away at any point for wellbeing purposes, I would encourage you to do so. So what is the IS? Victoria Police is a prescribed information sharing entity, or an ISE. We don't have any authority with regards to these schemes. We are just an ISE, the same as the agencies here today. We are just often consulted for guidance on information sharing, but it's usually just because of the unique data sets that we do actually hold. Our team mainly deals with requests under the FIS and SIS. We were created as part of the recommendations and findings from the Royal Commission into Family Violence to help alleviate pressure off operational police staff who were previously handling these requests. We receive requests from information sharing entities such as perpetrator services, AFM services, maternal health services, alcohol and drug programs, and so forth. So ISEs tailor their requests to their needs, and our team then validates the requests and proceeds to prepare responses in written reports to agencies and ISEs, who then can use this information for their own purposes. I will also provide a little bit later on just an example of what some of these reports can look like for those of you that haven't requested with us before. So on to the next slide. We are made up only of VPS staff. We don't have any operational or uniform police in our unit. As I mentioned, we were created to take pressure off those policing staff, so that is the purposes why there. We do not handle any urgent information sharing requests or requests for operational information. So when I refer to urgent requests, this is more like something within the day. So if someone contacts us in the morning and says, can I have this in 2 hours? That's something we would usually still deflect back to operational police because our team is not set up to handle that. In saying that, if you ever, do contact our team and you're not sure about if we are the right, point of contact or not, we'll always do our best to try and redirect you or find you the correct contact at Victoria Police to be directing your communications to as well. So yeah, we would never just shut you down and send you away. We will try to assist. It's just that sometimes it might not be through our unit that we can assist. So how do you lodge a request with us? On to the next slide. So all requests with us are lodged via a web form. Some of you here may have recently sought information from us and been asked to complete a manual form. This was just due to a technical glitch with the web form. So in all normal circumstances, we really need that web form to be completed. We appreciate that just about every person that requests from us is incredibly time poor. And sometimes you just want very basic information, and it might feel a lot quicker to just send us an email. But we will usually have to ask you to still complete the web form. The reason being, we as an organisation require several key components of information to verify your requests. And without it, we are unable to even justify searching someone and their police record in our system in the first place, let alone providing any of that information on to an external agency. So once the web form is completed, we receive it as a team, and a team member will begin the process of validating your request and assigning it with a priority level. You don't always need to say urgent in there. We do assess that anyway. Generally, things that might classify as urgent might be something like a perpetrator has just been released from being in prison. There might be an escalated risk. We can read between the lines and have a look at those things too. We firstly ensure that the requesting agency is a prescribed ISC as specified by the Child Wellbeing and Safety Amendment Regulations and Family Violence Protection Regulations. So we proceed to match the subject person, so the perpetrator of family violence, for example, using identifying information such as date of birth, any known names, addresses, and things like that. We use them to match in the police database, which most of you might know is called LEAP. And then we proceed to basically validate your request based on why you're seeking the information and the justification for seeking that request, which I'll cover on in a little bit in a second. So up on the screen, you'll see the ISC list page. As I mentioned in my previous slide, an important validation step for my unit is to ensure that any of the requesting agencies is a prescribed ISC as specified by the Child Safety and Wellbeing and Safety Amendment Regulations and Family Violence Protection Regulations. Most of you would likely already be familiar with this and the search function, but we do get a lot of new requesters that don't know their funding stream or how to basically label their organisation as part of requesting for us. So this is a really handy link, maybe as part of sending on to colleagues or making sure that anyone's aware of if they've just started lodging information requests to be making sure they can access this and see it. It does provide important things as well, like showing when someone is a prescribed risk assessment entity, which is very helpful for us to see as well when people are requesting with us. In the next slide, there is just a little bit of a breakdown on a chart that basically shows the terminology associated for an alleged perpetrator and a perpetrator. I'll go into a little bit more detail with this shortly, but you will see here we use the terms on our web form, and understanding why might help some of you. Importantly, we pay close attention to ISCs who are also an RAE and have the ability to request information on an alleged perpetrator of family violence for an assessment purposes. Most ISCs cannot do this, which is why we do pay attention to it, and can only request for a family violence protection or management purpose. So on to the next slide, you'll see an example of the web form questions, and pretty much straight out of the gate, you can actually see that there is a question, and it is asking you to basically allocate a title or a subject to the actual person that you're seeking on. So for example, one of the top things is alleged perpetrator and then perpetrator. You do need to indicate this and then provide us with a brief example as to why you are requesting on this subject and any important, risk factors or anything that we should be made aware of. Many ISCs kind of fall into the habit of copy and pasting generic information into this field, which is a bit unfortunate because the more specific you are, the more helpful we can actually be. For context, we're providing you in most instances with basically an insightful sample of a person's criminal behaviour relating to family violence. In many cases, a perpetrator can have an extensive history, and we can't provide it all to you because a lot of it would be unhelpful. And we also don't have the resources to do this for all of our requests. So if you tell us what you know and how, and what you're looking for, we'll go looking for information to add to what you know, or provide the gaps in the knowledge you do actually have. So for example, if you're concerned that a perpetrator that you're working with has a significant relationship between alcohol use and violence, tell us that so we can look for information or police commentary around those matters. We can also see where this person may have demonstrated violent behaviour towards non-family members when also known to be under the influence. So simply inputting AFM has disclosed family violence is a very generic response. It could be improved with AFM has disclosed ex-partner has committed family violence, including stalking, harassment and verbal abuse. We just have more to go on with that information. There is a character limit, so just keeping it dot pointed or a really simple short statement is completely fine. On to the next slide. So terminology, just reflecting back on this a little bit, we're very well aware that many agencies have their own processes in place for when labelling a subject person. So many of you actually seem to refrain from using the term perpetrator. And I know that there are all different reasons for that. And that's fine, but you will notice sometimes, and quite often we do push back a little bit and clarify with you, if you've put down an alleged perpetrator, we actually have specific criteria to call them an alleged perpetrator and justify sharing on them. So we consider a perpetrator of family violence when you know by either someone telling you, observing, you have police information, whatever it may be that indicates a person has committed family violence. It might be that a victim survivor has told you, yes, I've been harassed by my ex-partner. That is technically classifying this person as a perpetrator of family violence. It makes it a lot easier to understand that when you get a call from us and we say, can you just clarify why you're not sure if they've committed family violence? Because if you're not an RAE, we can't share if you're essentially fishing for that information. So that's why it is a bit of an important one for us. And we do get a lot of, I guess, confusion over that, which I do understand. But it's just a Victoria Police thing that, we do label perpetrator and alleged perpetrator, and it is also reflective of the ministerial guidelines as well. And on to the next slide. Yep. So this is a bit of an example of how to break down categories of information you are requesting from us. Some of you may have access to an L17 portal and don't need L17s provided to you from us. Others won't have access and you do need them. There is a difference between requesting an L17 summary and an L17 narrative, which is, it's very confusing, I know, but the summary provides a list of incidents along with corresponding dates and the relationship the AFM holds in each incident. The narrative provides the full details of the incident, so that write-up from police who attended the scene. And you can indicate that you would like both, or you can just have one, it's up to you. But just that's a common question that does often come up. On to the next slide. I've just popped some examples up here that just details what good or strong requests can be with us. So this is that background context that's really helpful for us to, in a generic way without providing information on a specific person here, that does really help us hit the mark to be able to share with you. So you can see the two differences here is the perpetrator has self-referred and admitted to using family violence, information required for risk management purposes, or something like the alleged perpetrator has been referred to our service and we are seeking any information on family violence committed for family violence assessment purposes. And then how do you receive a report? So when you lodge a report with us through the web form, you would provide your work email. You would then be receiving your report with the same email. We would send it to you in a password protected PDF document. The password's actually on the screen. It just changes every year, but it's very, very simple. And you just have to ensure that you're always keeping it confined to your work email and never a personal email is input, and the report is never forwarded or shared to a personal email as well. On to the next slide. This is just an example of an actual redacted report. I've just taken out the identifying information, but it does show some of the aliases and all of the date of births we can have recorded for a particular person. And the screenshot next to it has a bit of a breakdown of us including that summary of the incidents and the relationship between the perpetrator and the AFM. So for example, this one, it was a partner or a former partner, and there were 3 incidents, and those were the associated dates. And on to the next slide. We also can provide offence history. So we do stick to relevant offence histories only. We will not provide you a list of things that are completely unrelated to family violence or child well-being and safety. Things that can also be committed as a minor and it was 55 years ago and it was a theft charge from when they were a kid. That's the sort of thing we would withhold. But anything relevant, we would obviously share. And on to the next slide. So in offence history, this is just an example of what it looks like. We'll give you a little snapshot of whether it's been processed or authorised, and whether it's pending authorisation, which is just usually pending further evidence being obtained and a sergeant to sign off on the charge. And then on to the next slide. This is just a bit of a touch on the unstructured data that we can provide. So this is sort of best known as police commentary or flags, notably for violence, mental health, substance abuse, and weapons. We'll also share always if a perpetrator of family violence has an active firearms license and registered firearm. You can still ask about weapons, but just know that we'll always have that on our radar to be letting you know anyway. And then the following slide, there's actually an example of what unstructured data can look like. This is a mental health example, so just be warned that it does discuss an attempt to self-harm. And that's the sort of information we can include, which can be helpful to people working with these people that this context is really helpful. And then on to the last slide there. So these are just the things that they're not for our team. So really importantly, if you're ever reporting a crime or an incident, it's still to operational police, 000, obviously in an emergency. Sometimes we do pass intelligence on that you provide to us to operational police, but we shouldn't be used as the in-between. So if you have something you specifically need to make police aware of, please still do that in normal circumstances. It's more for our own intel. If you make us aware, for example, of an address that a perpetrator might be residing at, when there is an active whereabouts for that person, we might pass that on to police. We also only answer responses under FIS or SIDS on our team. And if you are requesting solely something like an IVO, you might be referred on from our team to somewhere like Courts Victoria, just because they'll probably get to it quicker than we would. And it's obviously something just quite brief that you need. And the only other final thing is that we only provide Victoria Police information. So the exception to this is that we can provide nationally recognised DVOs or IVOs to you, but it is a limitation of our service that we can't provide police information from interstate. Unfortunately, I know it comes up a lot, and it is definitely a limitation, but we can only share the data that we own, which is Victorian data. And yeah, that concludes my section of the presentation. Hopefully I got through everything in time, but happy to take any questions offline or here if needed.
Thanks very much, Courtney. That was really informative, and sorry to make you rush. It's always hard being the last person, I think. I do have there are a couple of questions in the Q&A directly for you, so we might start with them. The first one is from James, and he's got a question. the police are a really important stakeholder in family violence, domestic violence, but some organisations don't have strong links to their local police. Are you able to provide some advice on how to approach developing this relationship?
Yeah, that's a really, really good point. So a common, I guess, a common query I suppose our team gets is when there are agencies having a lot of difficulty establishing a good contact or a good operational kind of relationship with a local police member. Sometimes, yeah, like in suburbs or in regional areas, this can be a bit problematic. I guess at a local, it probably depends a little bit on the circumstance. From our team's perspective, we try really hard to suss out I touched on this very briefly in the presentation, but we will try and find out relevant contacts at a police station and discuss with them, you know, we've got a person who's trying to reach out to develop, you know, this kind of intelligence, or they're managing this certain risk to a person, and we try and engage them that way. Can be a little bit, I guess, dependent on the area. If there's a particular station where it's just, it is really difficult, I'm really happy to take feedback maybe offline, and that's something that could be also separately addressed, because it is a bit of a common one, I suppose. It's obviously police are very under-resourced, and sometimes, you know, trying to get a hold of them on the phone or email can be really difficult, which is sometimes where we can be helpful. But yes, I think improving their understanding of what you guys do as agencies and as people working in those fields, and how it actually benefits police as well, is a big part of the work that we have ahead of us still as part of this.
Okay, thank you. And there's also another one for you, Courtney, from Alice from Monash, who says, what happens when a victim survivor makes disclosures around family violence but is acutely unwell and may have impaired judgment or insight? Can information still be requested at this time?
Yeah, it's a good question. Yes, it can. So the way we interpret the guidelines is that we can provide the information that's been made available to us. So if you have a reasonable belief that there is a risk here and you've been made aware of it, even if the person, you know, their judgment or their I guess what they're saying to you could be under question, you can still request from us. We can actually then also provide, you know, a really common one is we can actually provide a context where, you know, you're working with someone who's accusing someone of family violence, and then we actually can look them up and see they've actually been a known perpetrator of family violence, or they've been, you know, constantly making, you know, false accusations and reports to police, which we can actually share as part of the schemes. It definitely meets the criteria to request from us, and we would respond based on that.
Thank you. I might ask a question of the Specialist Family Violence team. So the first one from Wendy is, are any of the SFVA representatives working across any of the private mental health hospitals?
That's something I can answer, Kate. I messaged Wendy, but as I said to Wendy, the roles were embedded within department-funded mental health and AOD service systems in 2019. So advisors don't cover the private service system. However, not sure if government is exploring this. That's something we're sort of looking at currently. Thanks, Kate.
Okay, thank you. And the other one is, are data collection processes in place for tracking the efficacy of the current released MARAM guidelines?
I can jump in. There is a bit of information. So there's yearly annual reports, I guess, that are specific for MARAM. It also falls into, I guess, like things like the family violence implementation monitor that's looking at the entirety of the family violence reforms. You'll often find related MARAM information and feedback in those reports as well. And I guess going forward, you know, a big piece of work that FSV is also looking at the moment is around, like, what is a maturity model? How do we know what it is and where we're getting there? How long does maturity take? So yeah, there's going to be a little bit more, I guess, structure around that as well going forward.
Okay, thanks, Erin. I've got a question from Michelle from Berry Street for Courtney Lucanto. How well do you think mental health practitioners understand their obligations under FVIS, which might challenge their perceived ethical obligations for client confidentiality? Anecdotally, I've heard instances where there has been refusal to share information about PUVs for the purposes of assessing and managing risk to the safety of their family members or intimate partners.
Yeah, it's a good question, Michelle. Thank you for asking it. I think obviously it's varied across the state. I think one of the things to understand in terms of mental health and psychiatry is that traditionally how it's kind of always conceptualized family violence, and how we've had things like the information privacy principles and the health privacy principles under the mental health world. But I also think too, it depends on how you ask it. So if you're actually asking under FIS through the centralized information sharing scheme request with big health services attached, and you're very clear about how you've received the information that somebody is a perpetrator, I think it invites a level of accountability from our service sector to understand that lens. So I think that will probably be just a tip in terms of if you're experiencing that or you're getting any of that sort of pushback, to actually say, how do you know they're a perpetrator? Well, I work for a family violence service. We've received the L17s. This is the information we're then seeing. And I also think too, if they're attached to our service sectors, making contact with the specialist family violence advisors in mental health to help you navigate that can also be helpful. Thanks.
Thank you. Just letting you know, there is going to be an evaluation that's going to be shared shortly. So I'd really encourage you to please fill that out if you can. I know we're really running out of time at the moment. I'll just ask one more question before we finish up. And that is, where can organisations seek secondary consultation support regarding family violence and risk assessment and management? I don't know who wants to answer that one.
I guess it depends what secondary consultation you're after. Certainly, if you're looking for support around working with men who are using family violence, then our MRS, Men's Referral Service, definitely does secondary consults. So you're welcome to call through, and a team leader will call you back. Otherwise, yeah, there's also your local specialist family violence services, including those working with victims, survivors, but also really important to keep in mind when we talk about secondary consults, you know, who's your local Aboriginal community controlled organisation? Will they support secondary consults for you? LGBTQI+ specialist services, like with Respect, for example, is one. So there's a couple, I guess. I don't know if Courtney or Kim or other Courtney wanted to jump in with others. But
yeah, I think that's fine, Erin. I think calling out places like the Orange Door, I saw in the chat that BARDA has very helpfully put up their list of secondary consultation resources that they created for their alcohol and drug workforces. So it might be worth, if you're not quite sure where to start with the family violence service sectors, having a look at that really helpful resource as well, because it can depend whether you need a statewide service or whether you need a regional service as well. Thanks.
Thanks very much, everyone. And thank you so much to our four presenters, Kimberlea, Courtney, Erin and Courtney. It's been a really informative session, and I think very much appreciated by all the participants, and really great insights that you've shared, and great to have that panel discussion at the end as well. I just wanted to also just reference the links that we've put into the chat for the grant recipients from the VHA, VARDA and the Centre for Excellence. Just if you want to follow up with anyone, those three links, they're happy for you to be contacted following the webinar with any questions. And I also am aware that Courtney and the others are also probably very happy to have any contact from you in the future. So this recording, the webinar has been recorded, and it will be available as per the usual process on the TriPeaks websites under TriPeaks. And thank you again for your attendance and participation.